whichever is put in the chat box and Q&A. Thank you and welcome all of you. And over to you, Deepak.
Good morning, sir. Today I'm presenting the case of oral cancer, oral tongue cancer. My patient is a 38 years old male patient who is a resident of Bangalore, who works in an IT company, comes with complaints of ulcer on the right side of the tongue since 1.5 months. He was apparently normal about 1.5 months back when he developed a cancer over the right lateral aspect of the tongue, which was insidious in onset and gradually progressive. It was initially about size of less than 1 centimeter. Now it's present size. He does not have any complaints of ulcer or pain in the ulcer or pain in the ear. He has no complaints of salivation or any discharge from the ulcer. No difficulty in opening the mouth, speech and swallowing. No complaints of hoarseness of voice. No complaints of any other ulcers in the oral cavity. No complaints of any in the neck. No cough, breathlessness, hemoptysis, and he does not have any back pain or long bone pains. Coming to the process of the treatment history, he has a history of usage of dentures for the traumatic tooth loss of the right central incisors 7 years back. Following the development of ulcer, the denture was removed for about a month back, and the tooth filing was done. Personal history: he consumes non-vegetarian diet, adequate sleep, blood and bowel habits are regular. He has a history of tobacco chewing for about 5 years, and he has stopped since 10 years. He doesn't have any history of usage of quid. He has a history of cigarette smoking for 5 years, about 5 cigarettes per day, and he has stopped since 10 years. He doesn't have any history of high-risk sexual behavior and occasionally consumes alcohol. Family history: he doesn't have any history of malignancy in the first and secondary relatives. On summarizing, my patient is a young male who presented with a painless progressive ulcer of the right lateral aspect of the tongue in the background of risk factors like history of usage of dentures, tobacco chewing, and cigarette smoking.
Deepak,
Sir?
Can I ask a question, Mahesh?
Yes, sir. Please go ahead.
So, Deepak, tell us that you asked for and you mentioned that there is no history of excessive salivation. Why did you ask so, and what were you trying to summarize?
Sir, in case of an ulcer in the tongue, the local irritation causes sympathetic activity, and that causes excessive salivation.
Anything else?
Local irritation, and also in terms of any infection in the infection.
So sometimes what happens is advanced tongue cancers, the patients are not able to swallow, and that is the reason probably sometimes you will find that they give a history of excessive salivation. Swallowing because of the advanced nature of the disease and pain causes excessive salivation. Go ahead.
And also, Deepak, it may be useful because salivation, if it's an inflammatory ulcer, then can also cause excessive irritation. And also in your history, you're asking about hoarseness of voice. What is the reason you were asking?
Sir, I was also looking for any primary lesions in the vocal cord or in the supraglottis.
Why do you expect that in this case?
Sir, oral pregnancy occurs as on the basis of field cancerization.
Yes.
So, oral cavity and the upper digestive tract.
How common is it? How common is synchronous malignancy in other areas?
Sir, synchronous malignancy is less than 5%. Every year, with the continuation of the habits, it increases. The 2 to 5% increases is a cumulative one.
Why did you ask for the history of pain in the ear, and what does it signify?
Sir, usually in case of advanced malignancies or moderately or locally advanced malignancies, there will be involvement of the lingual nerve, which causes deferred otalgia to the ear pinna and the preauricular region.
So what is the pathway? Dr. Trofan is asking, what is the pathway, how it happens?
Sir, the lingual nerve supplying the anterior two-third of tongue has got the same common origins from the trigeminal ganglion, which also gives the supply to the auriculotemporal nerve.
Through the chorda tympani nerve, what you're saying, no?
Sir. To the auriculotemporal nerve.
Deepak, why do you ask the history of high-risk sexual habits?
Sir, although the incidence of oropharyngeal adenocarcinoma is very unclear in India, in the Western population there is a HPV positive oropharyngeal malignancies are common. So, just as I asked about their sexual behavior.
But this is an oral cavity cancer,
Yes.
right?
Yes, sir. Oral and
So,
oropharyngeal.
your answer should be that this is the history taking.
Okay.
I have not yet examined the patient. Patient says that I have an ulcer in the tongue. It might be in the oropharynx, it might be in the anterior tongue. So during the history taking, I am supposed to take all these points because it might be a cancer which is going to the base of the tongue. It can be a oropharyngeal cancer. That is number one. And number two, what is the incidence of HPV positivity in oropharyngeal cancers in India?
In India is less than 10% sir, in India.
So it is from 10 to 20% according to the different studies. Okay. Right, let's go ahead. Okay, what is the specific history you asked when you said that he doesn't have a high risk sexual habits? What does that mean? What did you ask?
Sir, asked him about multiple sexual partners. According to the guidelines, it is more than 25 vaginal partners and more than 15 oral partners.
Okay.
Yes.
I'll go ahead, sir.
Yeah, go ahead.
On examination, he is conscious, cooperative, well-oriented, time, pleasant person. He is well built and well nourished with ECOG status of 1. His BMI is 27.7 kg per meter square. His BP is 130/70 millimeter of mercury in right brachiolateral supine position, and pulse rate is 72 beats per minute, and respiratory rate is 20 cycles per minute. And there is no pallor, icterus, and clubbing giants, lymphadenopathy, and edema. Examination of oral cavity. The examination is was done after the dispelling the patient about the examination and after the consent in a well-lit room. On examination, the mouth opening was adequate. Tobacco stains were noted on the teeth and on the gums. Oral hygiene was poor. Halitosis was present, and there was a loss of right central incisors. On examination of tongue, there is a ulceroproliferative lesion measuring about 1 into 2 centimeters, which has got inverted borders, and it is extending 3 centimeters to the tip of tongue and 2 centimeters anterior to the circumferential papilla, and about 3 centimeters from the midline and about 6 centimeters from the gingival lingual sulcus.
Can you say the size again and the extent again? Your voice was breaking up.
Sir,
No,
it was
Deepak, you were telling this is about inspection, no? This is inspection or what?
yes, sir. Inspection.
Okay. So you did not mention about did you mention about any sharp tooth or any fillings or any loose tooth or anything? Did you mention about that?
I also mentioned about the absence of the tooth and the other tooth were intact.
Okay.
It was ulceroproliferative growth on the right lateral aspect of the tongue, anterior two-third of tongue, measuring about 2 into 1 centimeters with everted edges. It was about 3 centimeters 3 centimeter distal to the tip of tongue, and about 1 centimeter anterior to the tegmental papilla, and 2 centimeters from the midline and 5 centimeters laterally from the gingival lingual sulcus.
Just hold.
But yeah, how can you measure by inspection? It's difficult, no? How do you measure by inspection? The size, extent, and everything. How do you measure?
So it's a on inspection. It's usually a approximate distance, sir.
Okay.
So the oral cavity was normal. There was no evidence of any leukoplakia or any other lesions. Movements of the tongue were normal, and there was no ankylosing. On palpation.
So hold on. So what does movements of the tongue, restricted movement, and the ankylosing mean?
Sir, in case of advanced oral tongue lesions, there will be involvement of the muscles of the tongue, which causes ankylosing, and also
Muscles. Which muscle?
geniohyoid and genioglossus causes ankylosing.
Which one? Geniohyoid.
Geniohyoid and genioglossus.
Okay. So extrinsic muscles involvement causes ankylosing and deviation of the tongue on the same side.
Yes.
This is a very important clinical feature that you must observe and mention. Okay.
So what are the muscles you know about in tongue cancer? In tongue, Deepak, what are the muscles you know?
Sir, there are actually two sets of muscles. One is extrinsic and intrinsic. Extrinsic will be genioglossus, geniohyoid, palatoglossus, tyloglossus, and the intrinsic muscles are horizontal and vertical muscles.
Longitudinal, yeah.
Can you, Deepak, can you tell me the origin and insertion of geniohyoid?
Geniohyoid, sir, it arises from the medial of the hyoid bone and inserts to the lingual septa as a fan-shaped muscle which inserts to the lingual septa.
That is genioglossus. I am asking you geniohyoid. You said geniohyoid, right?
Sir. It inserts to the tip of tongue, sir.
It inserts to the genial tubercle on the mandible, right?
Okay, sir.
So it is not actually a part of muscle which is taking part into the tongue movement. Is it?
Okay, sir.
Go ahead.
Sir. On palpation, mouth opening is adequate about 3 fingers. Ulcer is non-tender. The inspector findings were confirmed in terms of size and extent. On bidigital examination of the tongue, showed induration extending about 1 centimeter medially from the ulcer and anteriorly about 2 centimeters. Floor of mouth was free. No deviation of the tongue on protrusion.
Go back to the last slide. So I would suggest that you should mention the exact size when you are mentioning the palpation. Okay. Second thing is the mouth opening. You have mentioned adequate and 3 fingers. It would be a good idea if you present the mouth opening in form of centimeters.
If the patient has teeth, it should be from inter-incisor distance. So upper incisor and lower incisor, which you should measure with a scale. And if patient is edentulous, then it should be from alveolus to alveolus, and you must mention that this measure is from alveolus to alveolus in an edentulous patient, or whether it is incisor to incisor into a dentulous patient. Okay?
Why it is important to do that, Deepak?
Sir, if the to just rule out the involvement of masticatory muscles causing trismus.
So how does it affect the treatment part?
Sir, treatment part, the involvement of masticatory muscles, the extent of surgery increases.
Why you are talking about involvement of the masticator muscles in a tongue cancer? What I am asking is, how does mouth opening or restricted mouth opening affect your treatment part? How does it affect your management plan or approach?
Sir, it also signifies about submucous fibrosis which might be present in the.
Correct. So the point is whether you are able to do it as an intraoral excision or you need to do certain procedures for accessing the lesion. Okay. So if the mouth opening is restricted, you have to think of either a cheek flap or a mandibular tone. Okay. Let us go ahead.
So tell
So
me,
now again, can you say the exact size and the extent based on your palpatory findings?
Sir, on palpation, the ulcer was about 1 into 2 centimeters, extending was about 3 centimeters to the tip of tongue and about 2 centimeters anterior to the circumvenous papilla, and medially about 2 centimeters from the midline.
So you have mentioned 2 dimensions, 2 by 1 centimeter, correct?
Yes, sir.
What about the depth? Are you able to give me an idea about the depth of the involvement?
Sir, on on this digital examination, it was a thin lesion, about 1 centimeter deep.
Okay.
Deepak, if patient has a trismus, how will you examine the tongue?
Sir,
Patient is not able to say it is mouth opening is 1 centimeter.
okay, sir.
How will you examine?
Either I will do a examination under anesthesia.
No, before that, in office.
In office, sir, it's not possible.
So you will use a 0-degree or 70-degree telescopes, which are thin telescopes, through which you can examine the entire oral cavity through that 1 centimeter opening. Okay?
Yeah.
Go ahead, please.
Just so oral cavity is normal, then there is no evidence of sharp tooth or the loose tooths. And then there is no evidence of caries tooth also. Indirect laryngoscopy, it was normal. There was no evidence of second primary tumor. On examination of neck, there was no palpable lymph nodes on ipsilateral or contralateral side. On systemic examination, bilateral bed sounds were heard. On CVS, S1, S2 heard, and there are no added sounds. Per abdomen, no abdomen detected, and CNS, examination of 12th nerve was normal.
Go ahead.
Sir. Impression, a young male with a background history of high risk factors like tobacco chewing and usage of dentures. Under examination, there was a malignant looking ulcer with everted edges and induration all around. I would like to give the first impression as malignant ulcer of the right lateral aspect of the anterior tongue. Clinically, T2 N0 M0.
Why do you call it T2?
So T2, so it is I have included the ulcer along with the induration around it, sir.
So what is the size again? Can you repeat the size?
Sir, the ulcer was of size of about 1 into 2 centimeters, and the induration was extending medially for about 1 centimeter medially and anteriorly 2 centimeters.
Correct. So depth, you are saying that the depth was 1 centimeter.
Sir, 1 centimeter.
Okay.
Yes.
So why this is T2? Do you know the staging, clinical staging?
Sir.
Can you just tell me the clinical staging T1 to T4?
Sir, T1 is less than 2 centimeters, less than 5 mm depth of invasion. T2 is less than 2 centimeters, more than 5 mm depth of invasion, or 2 to 4 centimeters, less than 1 mm depth of invasion. T3 is more than 4 centimeters, less than 5 mm depth of invasion, or T2 to T4, 2 to 4 centimeters, more than 1 mm depth of invasion. And T4 is advanced with T4A is involvement of cortical bone or skin, and T4B is the involvement of pterygoid plates, pterygoid plates and internal carotid artery.
Or masticator space.
Or masticator space.
Okay. And you forgot one more thing in T4A. If the lesion is more than 4 centimeter and more than depth is more than 10 millimeter, then also it is T4A. So why this is T2? Because it is the depth is less than 1 centimeter, around 1 centimeter. Okay. So this is the reason why this is T2, and the size is less than 4 centimeter. Okay. So that is why this is T2 and 0. Okay, go ahead. So what is the difference in the staging system in the last TNM staging compared to the previous one?
Sir, in
for lung cancer, for oral cancers in particular?
Sir, with respect to the thing, there is addition of this depth of invasion, and also in the nodal staging they have added external extension as the N3B.
So what was there in the earlier staging system in tongue cancer?
This depth of invasion was not included, sir. It was only
correct. But what was included? Involvement of what? Involvement of extrinsic muscles was documented as T4.
T4.
It is no more there in the present staging system. That you should understand. Okay? Let's move forward.
I would like to do for this patient. I would like to do a PET biopsy, and the PET biopsy came as well differential squamous cell carcinoma. Then
so hold on, Deepak. Why would you like to do a wedge biopsy? Why would you not take a punch biopsy?
Sir, both can be done, sir. Since it's ulcer proliferative growth, punch biopsy would be more better.
How would you do a wedge biopsy?
Wedge biopsy, I would do at the edge of the lesion, which is a cone-shaped biopsy, which I will be doing.
Is it in the outpatient department or patient is taken into OT?
Minority, sir. Minority are taken into minority.
So that is the reason why you should do a punch biopsy, which is an office procedure, right?
Yes.
If it doesn't yield you the things, then you can think about going further, taking patient to the OT.
Yes.
Okay?
Yes.
The first should be punch biopsy. Unless the lesion is such that it definitely requires a wedge biopsy. Which are these lesions which will require a wedge biopsy?
Sir, usually this ulcer infiltrative lesions will need a wedge biopsy.
So the lesions which are borderline lesions which are varicoid lesions, right? These are the lesions where you would like to have the interface, and that is the reason why you would like to take a wedge biopsy. Very proliferative regions might not yield you a diagnosis by punch biopsy because the proliferative surface is full of squamous cells and you don't get the basement epithelium. So that invasive malignancy may not be stemmed. So in those kind of cases only you would require to go for a wedge biopsy. most of 90% of oral cancer cases can be diagnosed, or more than 90% as such, by a punch biopsy as an office procedure. So you don't unnecessarily take the patient to OT. Okay, let's go ahead.
So, what imaging you would use? You do an MRI?
Sir, T288 contrast imaging I'll do, sir.
Why would you prefer to do an MRI for this patient?
Sir, usually for T1 lesions and T2 lesions, the need of MRI is very less. But in this patient, I did because I want to know the midline extent of the lesion. That's the reason I did an MRI in this patient.
So you want to evaluate the primary lesion.
Yes.
Okay. So MRI is better than a CT scan for soft tissue delineation, particularly for tongue extension. It gives you a better soft tissue delineation. Are you interested to stage the neck also with imaging?
Sir, if I'm using the MRI for oral cavity, I would like to include the neck also. Otherwise, clinical examination and if necessary, ultrasound is enough.
So, what is the sensitivity and specificity of nodal presence,
sir,
by clinical examination versus ultrasound versus CT or MRI or PET scan?
Sir, CT and MRI has got the same sensitivity, sir, about 92 to 95%, whereas ultrasound with FNAC has got higher sensitivity for the neck lesions.
You
In
mean
which
for the
case?
neck?
Sir, pardon, sir.
In which case would you go for a CT scan in addition to MRI?
If the tumor is abutting the mandible, I would like to know the involvement of the cortical bone. So,
right.
Sir,
Go ahead.
Sir, this patient, the MRI whole cavity in the neck was done. It showed a ulcer over the right lateral aspect of the oral tongue, measuring about 2 into 2 cm anterior posteriorly and 1.2 cm transversely, and about 2.3 cm superior inferiorly. And there was no extension to base of tongue, and there was no infiltration of the extensive muscles of the tongue. And there was a enlarged right level to lymph node, which is about 1.3 into 1.1 centimeters.
So Deepak,
Sir,
you have sent the patient for MRI.
Sir,
and your radiologist sends back the patient that we will not be able to do an MRI. Why do we do that?
Sir, if the patient has any pacemakers or any oral implants or any cochlear implants, you send me back the patient.
So you must say that pacemaker which are not compatible with MRI. There are pacemakers which are available which are competent. So you must answer your question like that non-competent MRI kind of pacemakers or oral implants. Okay? Go ahead.
This also.
Deepak, going backward, sorry, I was unmuted. I was asking about the biopsy. Which is the punch biopsy? Which part of the ulcer do you want to take a punch biopsy?
Sir, I would like to do the punch biopsy of the at the edge of the ulcer, sir. Edge of the ulcer.
Edge. What is the reason? Why do you want to do it from the edge, not from the center?
So, central component of the ulcer might have some necrotic tissues. So the yield will be not useful.
Okay, so your chances of getting necrotic tissue is higher.
And also, I used to I will.
So the edges, what happens in the edges?
So edges are the most proliferating. Edges are the active proliferating part of the ulcer. So
Yeah.
I try to do that at the edge of the ulcer.
So if you don't have MRI, is it what do you say about ultrasound? How sensitive and specific is for lymph node metastasis? Because a lot of centers, peripheral areas may not have MRIs.
Sir, ultrasound has got a sensitivity of about 90 to 96%. So ultrasound can be used for the next staging in case of N0 neck.
What are the features of a metastatic lymph node in ultrasound? How do you say that it may be a metastatic disease?
Sir, a lymph node size of more than 1 centimeter, which is round, cortical thickening, hypervascular, and absence of and the architectural distortion and absence of fatty hilum.
Absence. And how the shape of the lymph node will be there? Will it be like elongated or it become?
Sir, it will become oval, sir, oval.
No. It will become more rounded.
Wider.
Yeah.
Wider than tall.
Okay. Wider than tall.
So I think only ultrasound doesn't have the sensitivity of more than 90% definitely. If you combine FNSC with ultrasound, the sensitivity is higher. But if you just have ultrasound, the sensitivity is better in CT scan and MRI compared to ultrasound alone. Okay, let's move forward.
The important thing in ultrasound is it is inter-observer dependent. So it's a subjective kind of an investigation, and that's the reason why CT scan or MRI would be better in the sense of documenting it properly and can be re-evaluated at a later date also by another radiologist or another clinician. Okay, let's go ahead.
Sir,
Yeah.
this is the MRI of the patient, sir.
Yeah, go ahead, show us the slides. Go ahead.
This is the node which was seen.
Stop at the representative cut. Can't stop.
Sir, please open your chat box.
Okay, fine. Tell me,
Sir,
when you go of the,
Do you have any axial views, Deepak?
whether
actually don't have.
involves hyoglossus or not.
Sir, this patient it's not involving hyoglossus, sir.
So tell me,
Why do you
Deepak,
say so?
in an MRI, apart from the size and the extent, what are you going to look for in a tongue cancer?
Sir,
What do you expect your radiologist to comment on?
I would ask him to comment about the involvement of the tongue muscles, sir,
Okay, what else?
and also the extent of midline midline extent,
Correct. Very good. What else?
and whether there is involvement of bone or not.
Very good. Anything else?
Uh,
Peritoneal invasion.
okay.
So,
In case of advanced
in an MRI, if there is a gross peritoneal invasion for named nerves, larger nerves, you'll be able to appreciate that too. And you have to be careful while you are operating such patients. Okay? So you have got one node positive at level 2 on the ipsilateral side.
yes, sir.
Tell me what is the incidence of contralateral node positivity in a patient with an N plus?
Sir, involvement of only one node on the ipsilateral side doesn't increase the incidence of contralateral mets. The incidence of contralateral mets depends upon the location of the primary tumor and bulky nodes, N2 and 3 nodes only.
Okay. So how will you stage this patient now after the MRI?
After the MRI, I would like to do a supraomoid neck dissection.
No. How will you stage this? What stage? What is the clinical stage that you want to say now?
Sir, it's clinically it's T2 N1 M0.
It's not T2 anymore. You said the depth. Go back to the MRI report, please. Can you go back to the MRI report?
Sir, it's 2.3 centimeters per anterior.
Correct.
Per inferiorly.
The transverse diameter is the depth, 1.2 centimeter.
Sir.
So the depth is more than 1 centimeter now. So it changes your staging. It becomes a T3 lesion now.
Okay.
So it's T3N1. So what stage it is now? T3N1 is what stage?
So, T3N1 comes to stage 3, sir.
Sorry?
Yes.
Stage 3.
Stage 3. Good. Okay? So remember this thing. When you do an MRI or a CT scan and if you have the final dimensions, please don't forget to mention that dimension and consider that dimension for your clinical stage. Okay? So your clinical inspectory and palpatory diagnosis was stage 2, while your imaging, including your imaging, it becomes stage 3. And that is the usefulness of imaging in a tongue cancer or any oral cancer. Will you do a PET scan for this patient?
No, sir. With this patient, I'm not doing PET scan.
Why? What are the indications of doing a PET CT in oral cancer?
Sir, PET CT is usually done to look for the distant metastasis only. And in case of recurrent disease or residual disease, usually see the do PET CT for evaluation.
So one indication is recurrent disease,
Residual disease.
residual disease. Okay.
For the distant metastasis, you can do CT or PET CT.
Okay. So what are the other indications of doing an upfront PET CT in an oral cancer? Would you do it in T1, T2, T3, T4?
No, sir.
T4?
T4, I would like to do for T3, T4 and involvement of the lymph nodes in the level 4 or level 5.
Correct. So the philosophy is, if there is a borderline resectable cancer, or if it's an advanced cancer with bulky nodes, multiple nodes, contralateral nodes, or level 4, 5 nodes, and where you want to find out the reason for not operating upfront, probably that is the time when you do a PET CT to rule out metastasis, distant metastasis. Okay? Okay, let's move forward. What else you have got?
Deepak, when you see an MRI saying that it is 2.2, 1.2 and 2.3 centimeter size of the tumor, does it really mean that the depth of the tumor is 1.2?
Sir, it also includes the Iteration also. No?
So it includes the proliferative part of the tumor also. So you must see clinically whether the tumor is a flat infiltrative tumor or it is an exophytic tumor. An exophytic tumor of 1.2 centimeter transversely may have depth of 2, 3, 4, 5, 6 millimeter also. You understand this? Because MRI shows and reports the dimension of the tumor. If your radiologist is an oncoradiologist, he or she will tell you that the size transversely is 1.2 centimeter, but the depth of the tumor is 6 millimeter or 10 millimeter or whatever, because then she will measure the depth from the surface of the epithelium adjoining. So it's extremely important for us to understand that the thickness doesn't mean the depth. Okay. So you must correlate in your mind with the difference between thickness and depth, and you must ask your radiologist that whether what they are seeing is a depth or whether this is a thickness. Okay.
So the transverse diameter that is mentioned, was it the depth or the tumor thickness in the MRI report?
They actually measured the tumor thickness, I guess. This MRI was done outside, so.
So Deepak, you should mainly understand the difference between tumor thickness and the depth of invasion. Most important, because your further decision depends on that. On your answer staging also depends on that. Because the depth is from the surface epithelium, not the thickness of the. Because in exophytic growth, you can have more thickness, but the depth will be less.
Because your MRI does not show, it doesn't look like the tumor has a depth of 1.2 centimeters. So we'll stick to our T2N1 stage. Okay? Okay. Great. So we are dealing with a stage 3 oral cancer, T2N1. Go ahead. What will you do for this patient now?
Sir, after doing the preoperative workup for the anesthesia and also with the consent of patient, I would like to do a 3-dimensional wide local excision followed by selective neck dissection 1 to 4 and MRND type 3, sir.
So you will do a wide excision with an MRND
type 3.
What is type 3 MRND?
Sir, in MRND type 3, we don't dissect the non-lymphatic tissues like interjugular vein or cerebral mastoid muscle or the accessory nerve.
So you are saying you want to do all level 1 to level 5 lymph nodes dissection in this case? What is the reason? Why do you want to do that?
Sir, since it's a 10 plus neck, so I would like to do a MRND type 3.
So even N1, it's the N1, no? N1 node.
Sir. N1 node.
So what would be the incidence of lymph node metastasis in level 5 level in N1?
Sir, incidence of lymph metastasis is, although it's less than 3 to 3.8% in level 5.
Yeah. So it's very low. It's very low.
Yes, sir.
So Deepak, with a MRI detected 1 centimeter or 1.5 centimeter kind of a lymph node at level 2, you will not jump for an MRND because the MRND has a morbidity which is much higher than compared to a limited neck dissection level 1, 3 or 1, 2, 3, 4. So going into the posterior triangle definitely adds to the morbidity. So the ideal operation for this would be a supraomoid or a extended supraomoid neck dissection.
Okay.
Anyway, if your nodes are going to be positive, you are going to radiate this patient. So whatever 3 or 5% chance of posterior triangle sub-centimeter lymph node being positive will be taken care of by the adjuvant radiation, and you must not give that morbidity to your patient. So the ideal operation for this would be a limited neck dissection. If there would have been a multiple lymph nodes or there would have been a lymph node which is of 3 centimeter size or more, then it would have been a different story. Or if your imaging finds out a posterior triangle disease. Okay?
So, Deepak, do you have any evidence to support whether you should do an MRND or an extended supraomoid type of a node dissection? Are you aware of any evidence?
Evidence for the incidence of
What is the literature support to do this kind of a neck dissection? Is it there, Deepak?
I think we lost Dr. Deepak. Sir?
He has come.
Dr.
Deepak, did you hear my question?
Yes, sir.
What is the evidence? What is the literature support to back your decision making?
Sir, in terms of hip metastasis, sir, we have this paper by Byers et al. Who shows incidence of metastasis to level 4 of about 15%. So that's the reason we are doing extended supraomoid neck dissection.
So, is there any evidence to support level 1, 2, 3, 4 dissection versus MRND, not doing an MRND? When any paper which shows both the procedures are equivalent in terms of oncological outcome?
Sir,
if I have to argue, I would say MRND. Why not MRND? Do you have anything to support that? There's a good Brazilian study, if you have read that, where the extended supraomoid or a supraomoid neck dissection has equivalent oncological outcomes. Okay? So you do a wide excision. How much margin would you take for the tongue lesion? And you do it intraorally?
Yes, sir. Paroral excision. I would like to do a palpatory. Let's do a 1 centimeter margin around from the edge of induration.
Good. So that is important. You must palpate the edge of induration and get 1 centimeter margin beyond that. Minimum 1 centimeter margin beyond that. Why 1 centimeter? What is the evidence to support the margin status? How much is the minimum margin that you need? What is the close margin?
Sir, histologically, margin of about margin of about 5 mm is adequate to have a clear margin, and 1 to 5 mm is a close margin. But since there is a maybe kinkage of the tissues, so I would like to do a 1 centimeter margin around.
1 centimeter, Deepak, 1 centimeter should be an unstretched margin, because what will happen when we are doing a partial prostatectomy, we usually stretch the tongue. So we should be careful in that. It should be unstretched 1 centimeter margin, because what will happen after the resection, it will contract and it will become 5 mm.
Okay.
Have you heard of anything about tumor margin shrinkage? How much does the margin contract after you resect?
No ideas.
Usually it is 20 to 30%. So what appears to be 1 centimeter to you, as Dr. Mahesh said, unstretched, when you resect it, it would almost become like 7 millimeter.
Okay.
Okay. So there are quite a few studies which have mentioned that if you have a 7 millimeter grossly free margin, the chances of the margins being microscopically negative are much more higher than less than 7 millimeter.
Sir. No, it's a Tata study, sir.
Yes. Will you do a frozen section?
Margin shrinkage.
Frozen section, sir.
Frozen section.
Sir.
Margin.
At our institute, we routinely send for the frozen section, sir. But if you are able to achieve more than 7 mm margin, there should be enough to achieve a negative margin.
And how will you do a frozen section?
Frozen section is done from the inserted margin to the tumor. That extent will take all over three-dimensionally.
So you will take margins from the patient side after resection, or you will send the specimen?
Specimen I will send, sir.
Good. And you will need to orient the specimen.
I will orient the specimen.
So what defect do you expect in this tongue? Will you reconstruct this tongue defect?
Sir, since this patient is he works in an IT company and he needs to the more of talking is required in this patient. I would reconstruct this patient.
What are the criteria for reconstruction of the tongue defect?
Sir, defect of more than 30%, 30%,
Yes.
and defect causing shorting of tongue, or defect that might cause about swallowing defects and all. For those patients, I would like to reconstruct.
Yeah, so Deepak, then I think you've done the surgery, you've done partial blasectomy and reconstruction and electronic lymph node dissection, MRND, what you have said. And if the what is your further, depending on the report, what is the final histopathology report?
Sir, the report has not come to the surgery.
Okay. So if it is a T2N1 lesion, what is the further course of action? What will do further treatment, adjuvant treatment for this patient?
Sir, depending upon the histopathology report, the LVI, PNI, and if margins are close, and after staging the neck, the level of the node involvement and the number of nodes, and external extension, if it's present or not. If it's margins are close and external extension are present, I would like to do concurrent CT-RT, and other factors I would like to do only RT.
T2N1 margins are free.
So T2N1 margins are free. I would like to if it's not LVI or PNI, I would just observe the patient.
Okay. So you want to give, okay, if it is N2 node?
If it's N2 node, I would like to give a RT to the patient, relation to the patient.
Okay. So when do you want to give a CT-RT in these patients?
Sir, in case of close margin or margin positivity, and also if it's N3B, external extension. So those patients, I would like to give us concurrent CT-RT.
So extranodal extension and margin positivity, what you are saying. So any evidence for that?
Sir, there is evidence from this pooled analysis of URTC 22931 and RTOG 9501. So they have showed a better local recurrence rate and disease-free survival.
Okay, they showed their benefit in only these two conditions, only either margin positivity or extracapsular. In those two conditions only, they have shown benefit of adding chemotherapy.
Yes.
That's what you want to say. Yeah. So, yeah.
So majority of the centers probably Deepak would radiate a N for N plus patient, unless it's a very small single node, less than 1 centimeter in size. So you must read the report very carefully. If it's a very deeply infiltrating, it could be still be T2. Suppose there is a depth of infiltration is say 8 or 9 millimeter, and if there is a single node positive, and with the size is around 2 centimeter, and the whole node is occupied by a metastatic lesion, probably the tumor board would, the multidisciplinary team would probably tend to radiate such patients. So it depends on what report you are facing, what is the biology of the disease, if it's a poorly differentiated, showing LVI, showing PNI. So all these factors are important to evaluate for an H1 treatment. So if it's a T2 and 0, then what would you do? With a depth of say 8 millimeter, T2 and 0, then would you radiate?
No, sir. No.
So there is a very good prospective randomized trial being conducted in India. It is still going on. It's called ARREST trial. You must be aware of this when you appear for the examination. That we are randomizing patients for post-operative radiation versus observation for T1 or T2 and 0 and the depth between 5 to 10 millimeter, because there is a lot of controversial papers available for oral cancer with a depth between 5 to 10 millimeter, whether to radiate or not to radiate. Okay? Good. So you said you will reconstruct with what?
I would like to reconstruct with the radial forearm free.
Okay. And what vessels would you use?
Facial artery and the IJV or the facial vein. One of them.
Preferably
So
IJV.
Deepak,
Right?
all patients you will reconstruct?
No, sir. Patients having more than 30% defect and lesions that might cause difficulty in speech and swallowing, and when there is shortening of the tongue. Only those patients I will like to reconstruct the patient.
So this patient has a 2 by 1 centimeter mobile superficial lesion, right?
Sir.
It is not involving hyoglossus. It is a superficial lesion. Why would you reconstruct this patient? This is a small lesion, less than 30% of the defect. Why would you do a radial fold?
Sir, with the taking the palpatory margin and about 1 centimeter extra, I would almost reach the midline for this patient, sir.
Okay.
So, doing primary closure for this patient would cause shortening of tongue.
Okay.
So that's the reason I would like to reconstruct. And his profession also is an aspect here, sir. So I would like to reconstruct.
Yeah, but what he's trying to say, if it's a larger defect, more than 30%, then only you need to reconstruct. Otherwise, the primary V closure is going to give you a much more result as far as the speech rehabilitation and swallowing is concerned. Okay.
So what is the downside of primary closure versus reconstruction by a microvascular flap?
The operative time will be more, and also in terms of further evaluation, the artifacts might be seen in the MRI.
So, the important thing is that when you do, for a small lesion, when you do a primary closure, you will oppose the muscle to muscle. So that's why the movement of the tongue would be better in a small lesion instead of putting a dynamic flap between these muscles. So that is the reason you should judge exactly what would be the outcome, a functional outcome of that patient.
Okay.
Because everyone, not an IT professional, even a singer, everyone, even a person who is coming from village would like to have a better voice. And definitely you are bound to give the best quality of life to every patient, not just to IT professionals. Okay? So unless there are other factors like what you rightly said, cost and things like that comes into the picture, you must try and give the best quality to these patients, and not necessarily putting a microvascular flap would give a best quality, because in a superficial lesion which is say 10% or 20% of the resection, you can definitely give you better quality of life by doing a muscle to muscle apposition and a primary closure, because in microvascular flap you have to dissect the floor of mouth, you have to bring the pedicle up, so it's a major dissection, and then that will also have some hindrance to the movement and speech of the patient. So you have to take into consideration everything and then take a call whether you would like to do a microvascular flap or a primary closure. Okay.
So tell me, Deepak, if you have to radiate these patients, what radiation would you use? What will be your field of radiation? What is the dose?
So, in terms of adjuvant radiation, I would like to irradiate the primary tumor and the involved nodal basin. IMRT could be used after three-dimensional planning, MRI planning and IMRT. The dose will be 60 grays.
So how much will you radiate bilateral neck or will you radiate ipsilateral neck?
Ipsilateral neck, sir. Ipsilateral neck.
Are you sure?
Sir, since there is no the contralateral neck involvement is very less in this patient, so I would like to irradiate the ipsilateral neck only.
Most of the centers would do a bilateral neck radiation in tongue cancer, and ideal would be an IMRT, and the dose to the contralateral neck would be definitely less than the ipsilateral neck, particularly the lower neck nodes. Okay, so I think we have overshoot the time. Maybe we can take up the questions in the chat box, Mahesh.
Yes, sir. That should be fine.
Absolutely. A lot of questions in the chat box.
So the first question was, in T-staging, tumor size signifies the ulcer size or size of the induration. So when you do a clinical examination, the answer is that you must consider the induration also when you clinically stage these patients. So I hope this is clear to everyone. Is FNSC of node needed on an ipsilateral side? Probably not unless you are looking for a case to observe the neck of the patient. But if there is a suspicious node on the contralateral side and if the lesion is not crossing the midline, probably an FNSC of the node on the contralateral side would be better. This will aid your decision making to do a bilateral elective nodal dissection also. For neck nodes, ultrasound versus CT scan. So if you combine ultrasound with FNSC, it's a better if you don't have availability of CT scan. But if you are going to use the modality for evaluating the primary and the neck, probably a CT or an MRI. CT is available very freely. So CT or an MRI would be better than doing an ultrasound only. You can get away with doing only an ultrasound for very superficial T1 or T2 tongue cancers, where you don't need to evaluate the depth or the perineal invasion. You are not worried about any funny extensions that you might find. If the lesion is not deeply infiltrating, you can get away without doing a CT or an MRI, but very early lesions. Mahesh, you want to take other questions?
There are a lot of questions in Q&A section also.
Yeah, so let me take Q&A. Manan Shah has asked, is it necessary to do USG neck in T1, T2, N0 tongue cancer when we are definitely going to address neck surgically? No, the question is wrong. You must understand that you are thinking that the neck is N0, but you need to do an USG neck at least minimum, because the palpatory finding of the neck can be false and you might miss multiple small lymph nodes which are cancerous. So that's the reason why you must do at least ultrasound of neck even when you are going to address the neck surgically, because you don't know whether you are going to do a limited neck dissection or a full neck dissection depending on the findings. Should IDL be done as a part of clinical examination in this patient? Of course. Any oral cancer examination is not complete without examining the oropharynx, hypopharynx and larynx, because as he rightly said, Deepak rightly said, there are chances of synchronous malignancies and you must address this as an part of examination. Is it necessary to do ultrasound neck in T1, T2, N0 when we are definitely going? It is the same question. Should ITL be done? Yes. Isn't adjuvant radiation therapy for N plus? No, as Dr. Toprani rightly discussed, limited small nodal positivity, single node positive. Still today, there is no standard indication for adjuvant radiation. The case will go to the tumor board. There will be multidisciplinary discussions. There are other factors like lymphovascular invasion, perineural invasion, the other factors like the patient has a chances of nodal metastasis, which is size of the lymph node versus size of the metastasis, and things like this will define whether this patient will undergo radiation or not. More than one node positive, of course, radiation would be definitely given. Sir, PMMC or deltopectoral flap used here instead of radial forearm? No, PMMC and deltopectoral flaps are inferior flaps to radial forearm flaps in these kind of settings. If it is a larger resection, maybe PMMC can be done instead of a perforator based ALT flap, but definitely microvascular flap yields a better quality of life, and that's why they should be done. Deltopectoral flap is a history. DP flap can be done in salvage situations where your PMMC and is already used or your microvascular flaps have failed. Sir, should we comment on depth of invasion clinically while mentioning clinical stage? Yes, it should be mentioned depth of invasion if you have an MRI or CT which is definitely suggesting the oncoradiologist is telling you that this is the kind of a depth they are seeing, or on clinical palpation, if the tongue is fixed, you know that the depth is more than 1 centimeter, and that's the reason why you would state that it is more than 1 centimeter, and you will stage the patient accordingly. I think I have covered everything, right?
Yeah, most of it. There are some more questions there. I think, they want to know the answer of the clinical trial, Toprani, which you are conducting. Now that you told everybody is worried, exams are coming, they want to write it down.
So it's called an AREST trial, AREST, and we are randomizing these patients T1, T2, N0 to observation versus adjuvant radiation, and the depth should be between 5 to 10 millimeters. So T1, T2, N0, 5 to 10 millimeter of depth, you will randomize them prospectively between observation and post-operative RT, because there is no clear-cut answer. Most of the places that in the tumor board meetings, the radiation would be jumping if the depth of infiltration is 6 millimeter or more. They would tend to radiate this patient, but there is no level 1 evidence yet, and so this trial will be able to give the answer maybe in the next couple of years.
Thank you.
More than 50% of the numbers have reached. So I think
accrual is good.
Yeah, accrual is really good, and this is a multi-institutional trial, so it is spreaded across India.
There is another question. Chest, any CT chest is indicated in early oral cancer? No, I don't think so. CT chest is indicated in early oral cancer. When you are dealing with T3, T4 or multiple nodal positivity patients, probably that is a time when you should be considering to rule out any metastasis in the lung.
So one more question. A lot of students will be having this question about contralateral neck node dissection. A lot of people have confusion with which conditions we should do contralateral neck dissections.
So when the primary lesion is approaching the midline, it is almost up to the midline or approaching the midline, I would certainly do in a tongue patient a contralateral elective supramoid neck dissection. That is minimum, even if it is an N0, because the chances of positivity in such patients is more than 15%, even in the contralateral neck, if it is approaching. So majority of the patient, particularly if it is an N plus on the ipsilateral side, I would not hesitate in doing a contralateral supramoid neck dissection.
So when it is crossing the midline or touching, or when it is involved in the tip of the tongue also.
Yes.
And also if there are multiple lymph nodes like N2 nodes on left side, one side, should we do the supramoid neck dissection on the opposite side in the lateral lesions?
Say that again.
No, Mahesh, I would not.
Yeah.
I
Do,
would not
yes.
I would not do the reason is that these patients are definitely going to be radiated post-operatively.
Yes.
And while opposite neck would be radiated in these patients. So that's the reason I would not like to add the morbidity of neck dissection and post-operative radiation to these patients.
So the answer would be in a clear lateralized lesion, there is no need to.
Thanks, Mahesh. I'll have to tell you, this was an outstanding clinical meet. I have to tell, I am so happy, overjoyed. I got the 3 best people in India who could do justice to head and neck cancer. Not many people know, Rajendra Toprani and then Kaustubh Patel. They are our great seniors. They are authority. They are like, we call both of them Indian JP Shahs. They have a vast knowledge, excellent, coupled with evidence-based. Their knowledge is so much we can run another 10-15 classes. Why? One of the reason I requested 2 busy, decorated head and neck surgical oncologists to spare time for all our students is, most of the DNB practical exam are passed and failed only in 2 cases. LABC breast cancer and head and neck cancer. Take my word. Of the 4 cases which you need to present in practical, pass, fail, unfortunately is decided in first 2 cases you present. If you have taken all the 4 cases, you have an option of presenting any 2. Please present the 2 best you think you are good, because first 2 cases are extensively analyzed by examiner in practical, and pass, fail almost decided in that. Case 3rd, 4th and afternoon, rarely too much it matters unless you are in borderline. And most of the fail, when I go as an examiner, 90% of the people fail in oral cancer. They know everything, they don't know how to put it. And this class has been so wonderful. It took me back to my MCH training. And, I profoundly thank Kaustubh Patel, Rajendra Toprani sir, and Mahesh, my close colleague. This shows that we need to put another 5-6 such classes. Rightly and aptly, next Saturday, the 2 doyens of head and neck surgical oncology, Rajendra Toprani and Kaustubh Patel, are going to give faculty talk. How do you manage and approach neck nodes in oral and head and neck cancer? How do you manage oral cancer? General principle concept. So this adds a beautiful introduction to the talk next time. Don't miss. You know that in DNB, we don't repeat. We are not going to give you slides, and we are not going to put it online YouTube. So you think you will watch, which you never watch. You have to attend live if you don't want to miss it. All your other unanswered questions will be taken up in the next Saturday faculty talk by the same 2 faculty. I really love this. It's a beautiful session. Students, keep in mind, all your fail pass happens only in 2 cases in practical: breast, LABC and head and neck cancer. So don't keep any doubt. Attend all of them. Write down the notes. And I profoundly thank, Mahesh, his student, he did well. But this shows that in head and neck cancer, you need many years to master it. And thank you very much, Kaustubh Patel bhai, and then Toprani. They both were my seniors. I learned a lot from them. And they're great teachers, great surgeons. Thank you very much. I thank Navneet Singh ji for sparing this time. We know we will overshot a lot, but the topic is such that it depends.
Dr. Soma, I am speechless and overawed by your speech. And I must congratulate you for taking this leadership, for continuing this teaching program for the students. It's a great job that you are doing. Keep it up. Your enthusiasm is great. I'm surprised how you are able to find out so much time for teaching and your passion. So good, great job.
If you see, more than 350 students have logged in. And that shows how much useful your contribution is. Thank you very much.
Tom, thank you so much.
Thank you.
Thank you, Mahesh. Thank you.
Thanks, sir. Thank you, sir. Kaustubh bhai, thank you.
And the student did well.
Yes,
You
sir.
did well. So keep it up.
Deepak,
Thank you very much,
and,
Dr. Deepak, for the
definitely,
presentation.
And thank
Keep
you,
up.
Dr. Kaustubh, Dr. Mahesh, Dr. Somasekhar, and Dr. Rajendra for joining us. And thank you, trainees and faculty members, for joining us.
Thank you.
Thank you.
Thank you.